Mhm. A very good morning and my hand-folded greetings to all the delegates on this global platform. Myself, I am Dr. Reecha Gupta, Professor and Head, Department of Prosthodontics in Crown and Bridge and Dental Materials in Indira Gandhi Govt Dental College, Jammu, from Jammu and Kashmir. The technology today has affected almost every aspect of 21st century, and dentistry is no behind. The topic which I am presenting today is 3D reconstruction in maxillofacial prosthodontics, the art of reanimating the dead. I begin with the introduction of the specialty prosthodontics. Prosthodontics is the dental specialty pertaining to the diagnosis, treatment planning, rehabilitation, and maintenance of the oral function, comfort, appearance, and health of patients with clinical conditions associated with missing or deficient teeth and maxillofacial tissues using biocompatible substitutes. It is a branch with a wide scope and caters replacement of missing teeth with complete dentures, removable cast partials, fixed partial dentures, implant supported dentures, and replacement of missing maxillofacial structures with maxillofacial prosthesis. Maxillofacial prosthetic branch is one of the maxillofacial prosthesis is one of the branch of prosthodontics which is concerned with the restoration or replacement of stomatognathing and craniofacial structures with prostheses that may or may not be removed on a regular or elective basis. This branch has evolved tremendously in the recent times. Abraham Lincoln once quoted, "The best way to predict your future is to create it." And he was very right. Here is the picture of a person, so scary indeed. It is taken from one of the journals of craniofacial maxillosurgery. We are in a no position to imagine the amount of agony, the emotional state of this patient. But when surgical options fail, comes the role of a maxillofacial prosthodontist to recreate what God created. Imagine the level of satisfaction the recreator must have felt. Maxillofacial prosthetics is not new. The earliest known restoration of facial appearance and dental occlusion is attributed to the times of Hippocrates. Etruscans were a little advanced in the art of intraoral prosthesis, as evident from the remains of prosthetic structures found in the ancient burial sites. This is the pic of artificial eye given by the ancient Greeks with enamel-covered silver eyes and bronze lids. Another picture of the skull of a woman some 5,000 years old, where archaeologists in Iran have found with a prosthetic eye made of tar and animal fat. Ambrose Paré, the French surgeon, documented the first use of maxillofacial prosthesis in 16th century. He mentioned the use of artificial nose, artificial eyes, and palatal obturators. The currently materials used include acrylic resins based on polymethyl methacrylates, polyurethanes, latex, and silicone polymers. The material of choice, however, is silicone polymer. The advantages associated with acrylic resin: it's easy to work with and to maintain, it's durable, it's easy to reline with the tissue conditioner or reliner, both extrinsic and intrinsic coloring can be performed, and it's compatible with most adhesive systems and can be cleaned easily. The demerits associated with acrylic resin are its rigidity. It does not have the feel of skin, high thermal conductivity, poor margin aesthetics, and the presence of surface gloss. Silicones, on the other hand, they can be room temperature vulcanizing silicones or high temperature vulcanizing silicones and have several advantages. They have excellent tear and tensile strength over a range of temperature. They are easier to manipulate. They have high degree of chemical inertness, low degree of toxicity, high degree of thermal and oxidative stability, Further, they can be stained intrinsically or extrinsically to give them more lifelike natural appearance, simple cleaning, and safe and sanitary as compared to other materials. But major demerits of silicone are color degradation and instability caused by exposure to UV light, temperature variations, and humidity. Moreover, this frequent replacement required almost every microbial growth, poor strength, and poor wettability are another disadvantages. Post-COVID times has seen a sharp increase in patients requiring maxillofacial rehabilitation. Plastic surgeons replace the missing tissues by one's own skin rather than making an artificial substitute. This method no doubt has the advantage of matching the patient's skin color to that of grown tissue. Rejection of tissue is eliminated and retention of tissue is neater via surgical stitching. But maxillofacial prostheses play a vital role in comprehensive rehabilitation by restoring physical and psychological well-being in patients with missing or disfigured anatomical structures in conditions like large malignancy, lesions likely to recur following a surgical procedure, poor vascularity at the site of deformity, or poor candidates for extensive and multiple surgical procedure. In such conditions, maxillofacial prosthetic restoration is the choice. Facial reconstruction in such cases not only reestablishes patients' aesthetics, functional rehabilitation, speech correction, but also supports patients' mental health, help them to re-engage in society again, the outcome of which is directly dependent on the level of satisfaction with the prosthetic rehabilitation. The conventional method involves steps like taking an impression, manufacturing a cast, and ultimately handcrafting a prosthesis in a silicone-based or a similar material. The provision of prostheses in this manner no doubt gives considerable comfort and support to many patients over many years and allow them to continue with normal day-to-day activities and enhance their social interaction. But there are certain limitations associated with it. Technical expertise is required. A lot of time is consumed, multiple steps, effort on the part of operator, cost, retention problems, durability issues due to material degradation, and color fading and instability. And for these reasons, facial prostheses require renewing and periodic replacement, which is a costly and time-intensive process and places a burden on both patients as well as prosthodontists. So here comes the need for technology, the 3D printing technology, a step forward towards changing traditional dental practices. The technology capable of generating physical objects from graphical computer data, the era of 3D technology. It comes with a huge scope in the production of auricular and nasal prostheses, in the fabrication of intraoral obturators, in the duplication of existing maxillary and mandibular prostheses, manufacturing of surgical stents for patients with large tumors scheduled for excision, in the manufacturing of lead shields to protect healthy tissue during radiotherapy, and fabrication of burn stents where burnt area can be scanned without subjecting delicate sensitive burn patients to elaborate impression taking procedures, and so on. Here is the picture of few 3D printed prostheses. We can very well appreciate it, the eye prostheses, the auricular prostheses, finger prostheses, and so on. Now, what is 3D? The term 3D is generally used to describe a manufacturing approach that builds objects one layer at a time, adding multiple layers to form an object. 3D printing technology was first demonstrated in 1980s. It is also referred to as additive manufacturing rapid prototyping, solid freeform technology, layered manufacturing, or direct digital manufacturing. That is layer by layer addition technique which continues till the prototype is totally manufactured. Now here is a workflow comparison between 3D and conventional maxillofacial prosthesis. The time required, the traditional methods we can very well appreciate requires at least 3 to 5 patients visit in contrast to 3D procedures where only 1 to 2 patient visits are required. The comparison also says 3D printing saves time. It has high precision manufacturing, short manufacturing cycles, simple production process, low production cost, high accuracy, high precision, early visualization of processes design. And all these make it promising for application in the maxillofacial prosthodontics. The advantages clearly are the main benefit is that the models can be produced with undercuts, voids, intricate internal geometric details, and anatomical landmarks, leading to improved diagnosis, precise treatment plan, and shortened treatment time. And this eliminates any faults caused by human skills and so is comparably very, very time consuming. Also, quickly delivers a better design communication tool. The physical prototype quickly and clearly communicates all aspects of design. It facilitates the early detection and correction of design flaws, gives designer the ability to quickly turn concepts into 3D models or prototypes. It's a clean process, wastage is negligible, complex shapes can be produced, easy to use, no skilled person is needed, and reduced design complexity. But it has, again, its own limitations, like the high cost of equipment, cost of raw materials, complicated machinery needed, reliance on special expertise to run the machinery, associated, of course, with misuse of technology. And although 3D printers have the potential of creating many jobs and opportunities, but they might put certain jobs at risk. But the expense could be justified in the light of results achieved, and also the benefit from the elimination of impression taking procedures in especially such medically compromised patients. The method of fabrication, the 3D data is acquired with a 3D scanner. The 3D modeling software then converts it into a STL file to translate the 3D shape and slice it into digital layers. The STL file is transferred to the printer, which builds the model layer by layer until the part is complete. Then the laser is used to cure the liquid resin into hardened plastic in a process called photopolymerization. Post-processing like polishing or painting may or may not be required. It has a huge scope. Prosthesis with 3D printing finds its scope in intraoral palatal obturators, as can be seen in these views, and for extraoral pictures, for the defects of auricular prosthesis, nasal prosthesis, and orbital prosthesis. Here is a view of one of the video presentation to appreciate the process of 3D printing. The source of video has been mentioned in this slide. Have you ever seen someone happy? That's what I'm feeling. I'm happy. This is perfect. Really, oh my God. It does not look like I have a prosthesis. These are the patient's words. We can very well appreciate the amount of happiness on a patient's eyes and on his face post-operatively. And this is so overwhelming. There is a saying, a picture is worth 1,000 words. And with 3D dentistry, it can be rightly said, one real prototype is worth 1,000 pictures. These are few of the pre and post-op pictures, which are the clear examples, and the sources have been references have been given below in the slide. We can see how beautifully the aesthetic forms and anatomical contours have been re-established in these patients. Life often imposes things that one cannot control, but still we have the choice of how we are going to live through it. But this is not how the story of such patients is going to end. We have only scratched the surface of 3D world. Its full potential is yet to be explored. Let's not limit ourselves. After all, it's the God-given right of every human being to appear human. Thank you and have a good day.